The following podcast is part of a certified educational activity titled Anticoagulation Therapy in Non-Valvular Atrial Fibrillation, a quality improvement initiative. Access the entire activity and complete the post-test at peerview.com/MXE860. Downloadable slides and practice aids are also available.
Welcome to this educational activity on improving guideline concordant anticoagulant therapy for stroke prevention in patients with atrial fibrillation in the real world. This activity will describe the practical, evidence-based methods that were associated with increasing appropriate anticoagulant utilization in a University of Florida quality improvement initiative. After completing this activity, you should be able to recognize the burden and consequences of untreated non-valvular atrial fibrillation, assess barriers to the optimal use of direct-acting oral anticoagulants, or DOACs, and employ guidelines, new data, tools, and quality improvement strategies to overcome barriers to the evidence-based and guideline-directed use of DOACs in patients with atrial fibrillation. Atrial fibrillation is the most common arrhythmia in the world, affecting about 1% to 2% of the U.S. population, with approximately equal prevalence among men and women. That number is expected to increase as the population ages because the incidence of atrial fibrillation rises with age. Atrial fibrillation can cause bothersome symptoms, including syncope, but for many individuals, the disease is asymptomatic. Many risk factors for atrial fibrillation overlap with those for cardio-renal metabolic diseases and are potentially modifiable, such as hypertension, heart failure, obesity, diabetes, and obstructive sleep apnea. Cigarette smoking and alcohol use also increase the risk of atrial fibrillation. Atrial fibrillation is one of the most critical risk factors for stroke. According to some estimates, more than 80% of cardioembolic strokes are related to atrial fibrillation, as are roughly a third of ischemic strokes and potentially a third of cryptogenic strokes. Importantly, atrial fibrillation-related strokes cause larger areas of brain infarction, greater disability, and higher mortality compared with strokes from other causes. But there is good news. Atrial fibrillation-related strokes have highly modifiable risk factors. In clinical trials, oral anticoagulants have been shown to reduce the risk of stroke by more than 64% and to reduce stroke-related mortality by more than 25% relative to placebo. Not every patient with atrial fibrillation will benefit from oral anticoagulation therapy. A consortium of medical societies in the United States, including the American College of Cardiology, the American Heart Association, the American College of Chest Physicians, and the Heart Rhythm Society, have developed guidelines defining which patients with atrial fibrillation will benefit most based on their CHADS-VASc score. The European Society of Cardiology, the European Association of Cardiothoracic Surgery, and the European Heart Rhythm Association have published similar guidelines. The CHADS-VASc risk calculator estimates atrial fibrillation-related stroke risk according to a composite of 8 risk factors. The most prominent risk factors are advanced age and a history of stroke, transient ischemic attack, or thromboembolism. Other risk factors include heart failure or left ventricular dysfunction, hypertension, diabetes, vascular disease, and sex. Click on the Practice Aids icon to access and download free resources detailing the scoring systems for CHADS-VASc. Oral anticoagulants are strongly recommended in patients with CHADS-VASc scores of 2 or higher in men or 3 or higher in women. They may also be considered for patients with CHADS-VASc scores of 1 or higher in men or 2 or higher in women. For patients who have a history of acute coronary syndrome or percutaneous interventions, oral anticoagulants are recommended with CHADS-VASc scores of 2 or higher regardless of sex, unless bleeding risks exceed the benefit. Current guidelines rely upon clinical judgment to determine the benefit of stroke risk versus the bleeding risk. Previously, the has bled score was used to make this assessment, but it is not recommended to be used in isolation, since the factors that increase bleeding risk also increase stroke risk. However, registry data from the American College of Cardiology's National Cardiovascular Data Registry, Pinnacle, demonstrate that only about half of the patients with atrial fibrillation who satisfy the CHADS-VASc scoring criteria for anticoagulation are using oral anticoagulation therapy. The benefit of anticoagulation therapy is greater at higher CHADS-VASc scores, but contrary to the evidence, the proportion of treated patients was similar whether the CHADS-VASc score was low or high. Especially troubling is the fact that a substantial minority of patients are using aspirin or aspirin combination therapy for anticoagulation. Aspirin is less efficacious and less safe than oral anticoagulants and is no longer recommended for stroke risk reduction in patients with atrial fibrillation. The newest U.S. guidelines recommend only anticoagulants for this purpose. Aspirin increases the risk of gastrointestinal bleeding without reducing the risk of stroke in patients with atrial fibrillation. The Pinnacle Registry also demonstrates wide variations between clinical practices in the proportion of patients prescribed oral anticoagulants. The median treatment prevalence was about 52%. Wide practice variations such as these indicate suboptimal quality of care. What factors contribute to the low prescribing rates of oral anticoagulation in the United States? This question has been researched extensively, and barriers have been identified at every healthcare system level. While we only have time to discuss a few, here are several of the most important factors for quality improvement initiatives. At the practice level, barriers to coordination and continuity of care are prominent. Discordant appointment expectations were also cited. Another factor is that patients may feel that follow-up visits are a waste of time if no changes are made to their treatment regimen. At the provider level, calculating a CHADS-VASc score may be subordinated to other, more urgent clinical concerns, but medication-related barriers are prominent. Understandably, providers are cautious about using these agents due to known bleeding risks. Providers may question the balance of benefits versus risks, lack awareness of anticoagulation reversal agents, or be uncertain about the correct dose or how to address potential drug-drug interactions. At the patient level, one survey found that forgetfulness was the most prominent barrier to oral anticoagulation use. Other patients reported that taking the oral anticoagulant did not seem important, or that it would be okay to skip a dose if they did not have any symptoms. Patients may not understand that they are still at risk of atrial fibrillation and require anticoagulation even after undergoing a successful ablation procedure. Still, other patients are concerned about bleeding and bruising or out-of-pocket costs. Given the evidence of the benefits associated with oral anticoagulants and the suboptimal use rates, the underuse of oral anticoagulation therapy among patients with atrial fibrillation has often been a focus of quality improvement initiatives. The Support AF2 study addressed provider-level barriers through electronic health record alerts, email notifications, and mobile apps. Support AF2 successfully increased anticoagulation prescription rates but did not address patient barriers to oral anticoagulation therapy. Enhance AF studied a shared decision-making tool for patients and clinicians. This study successfully reduced patients' decisional conflict about oral anticoagulation therapy but did not increase oral anticoagulation use. Help AF was a home-based, structured, patient-centered education initiative to increase oral anticoagulation use. The investigators have published their patient education materials, but the primary study outcomes have not been reported. In late 2018, the University of Florida, Jacksonville participated in a quality improvement initiative to increase oral anticoagulation rates among patients with atrial fibrillation. This initiative originated from the Heart Rhythm Society and developed into the Preventing Preventable Strokes Pilot Project, or the PPS Pilot Project. Synthesizing the best practices of prior atrial fibrillation quality improvement initiatives, the PPS Pilot Project attempted to address barriers to oral anticoagulation use at the practice, provider, and patient levels. Practice barriers were addressed through a best practice alert within the electronic health record system. Provider barriers were addressed through clinician education, and patient barriers were addressed through communication. At the time of the University of Florida Jacksonville's PPS pilot project launch, 2,357 of the 3,555 eligible patients, or about 56%, were on oral anticoagulants. At study's end, 6 months later, the percentage of patients on anticoagulation therapy increased by 1.5% to about 58%. Based on the population of untreated patients at the University of Florida, Jacksonville, given the stroke rate for untreated patients, which was estimated from large registry data, and assuming the absence of any competing or secular trend to explain the growth in anticoagulation use, this 1.5% increase in patients receiving anticoagulation treatment could result in the prevention of 1.5 strokes over 1 year. Although there was a steady increase in anticoagulation use, the trend was not statistically significant when conventional linear regression modeling was applied to the data. Encouraged by the partial success of the University of Florida Jacksonville's PPS pilot project, the Quality Improvement Initiative was replicated with improvements at the University of Florida Gainesville. The University of Florida Gainesville's Quality Improvement Initiative used the same approach at the University of Florida Jacksonville, but enhanced each of the interventions in the triad model, as will be discussed. This project was titled the PPS Scalability Project, or the PPSS. PPSS followed the interactive Plan, Do, Study, Act model, which is widely applied in clinical practice. In the planning phase at the University of Florida Gainesville, benchmark data were collected in the EPIC electronic health record based on the ICD-10 code for atrial fibrillation. The PPSS retained all the primary features of the original PPS pilot project, including the triad of interventions to address practice, provider, and patient barriers to anticoagulation therapy. The size of the team expanded, and the amount of clinician education was increased. The triad approach addressed practice-level barriers using a best practice advisory, or BPA, which was developed and deployed as an alert in the EPIC electronic health record system. Provider-level barriers were addressed through clinician decision-making support tools. An online educational activity was developed and made available on the Heart Rhythm Society's website to permit clinician self-assessment using case vignettes. A multidisciplinary Grand Rounds presentation and online webinar with a national expert was also developed. Patient-level barriers were addressed through EPIC's MyChart messages. Patients were also sent emails and mailed educational letters explaining their stroke risk status and follow-up recommendations. Sample letters have been included in the downloadable practice aids for you to use in your quality improvement initiatives. Click on the practice aids icon to access and download these free resources. PPSS required a much larger team to organize, perform, and manage the activity across the University of Florida Gainesville's network of cardiology and primary care clinics. The PPSS steering committees and staff included clinical, administrative, technical, and educational experts. The pharmacy department played a key role in overseeing PPSS and generated monthly data reports to monitor progress. A core team consisting of the lead clinicians, the pharmacy team, an administration representative, the Heart Rhythm Society, and PeerView Institute for Medical Education held bi-weekly meetings to analyze data and form a plan of action. The core team presented progress on the Quality Improvement Initiative to the University of Florida Steering Committee every other month. The action phase consisted of notifying clinical providers through BPA alerts, providing educational materials for providers to assist with clinical decision-making, and collecting feedback on the clinical office group's performance. There were 7 goals of the PPSS. 1. To increase the guideline-directed use of oral anticoagulation to prevent strokes at the University of Florida Gainesville by testing the transferability and scalability of the University of Florida Jacksonville's PPS pilot project. 2. To increase patient awareness of their stroke risk. 3. To increase patient adherence to medication. 4. To increase clinical awareness of their guideline-directed use of oral anticoagulation to prevent stroke and compare their performance with their peers. 5. To increase clinician knowledge of clinical practice guidelines for anticoagulation therapy to prevent stroke. 6. To increase clinician use of shared decision-making tools with patients at risk for stroke. And 7, to increase the efficiency of PPSS implementation in comparison to the original PPS pilot project. The original PPS pilot project had many strengths. It was large for a pilot study with approximately 3,000 patients at multiple clinics and showed slow but steady improvement in anticoagulation use over 8 Plan Do Study Act cycles. However, the PPS pilot project did not place enough emphasis on clinical practice. In the scalability study, a steering committee was established and a higher level of administration support was obtained. To address insufficient patient communication in the PPS pilot project, the PPSS targeted specific patient groups according to their CHADS-VASc risk and need for anticoagulation therapy. Messages were sent using multiple tools on a larger scale, including postal letters and MyChart messages. Another difference in the PPSS was the expanded role of pharmacists. The pharmacy team tracked all the data and communicated with the clinical pharmacists responsible for answering patient questions directly. The clinician education components of the PPSS added an online self-assessment and Grand Rounds webinar to the prior clinician education interventions. Extensive organizational structures were established to address the first arm of the triad, practice-level barriers. The PPSS was organized in the University of Florida College of Medicine and included the University of Florida Health Physicians and the Continuing Medical Education Office. The physicians came from cardiology, internal medicine, and family practice clinics and were supported by University of Florida pharmacists, a medical society, and 2 independent continuing medical education providers. The principal investigator, Kunshong, MD, PhD, came from one of the cardiology clinics. The primary responsibility of the steering committee was to manage the administrative aspects of the Quality Improvement Initiative. The steering committee included section heads and chairs from general internal medicine, cardiology, and pharmacy. The primary responsibility of the core team was to manage the operations for the Quality Improvement Initiative. The core team consisted of multidisciplinary representatives from multiple teams. Many members of the steering committee also served on the core team. Due to the COVID-19 pandemic, there was a delay in completing the PPS pilot project. After resolving various administrative details and technical issues related to the implementation of the BPA alert, baseline data collection for PPSS began in June 2022. The clinician education activities were distributed in October 2022. Study data were then collected for 6 months starting in January 2023. These data were analyzed in August 2023, presented internally to the University of Florida in September 2023, and disseminated in meeting abstracts and professional journal articles beginning in January 2024. The Best Practice Advisory Alert, or BPA Alert, required close coordination with the Information Technology Group. The initial BPA Alert for the PPS pilot project linked clinicians to an order set for medication prescriptions and to clinical guidelines. The BPA alert was simplified for PPSS based on feedback from the primary care clinicians to make it easier to use in practice. The alert was triggered for patients diagnosed with atrial fibrillation and who met CHADS-VASc criteria for anticoagulation use but did not have an active prescription for an anticoagulant. The HAS-BLED score calculator was initially included at the request of the primary care clinicians, although after the BPA alert was developed, the ACC, AHA, ACCP, and HRS guidelines for atrial fibrillation were updated to reduce reliance on the HAS-BLED score. The newly published guidelines do not recommend HAS-BLED be used in isolation in the clinical decision-making for anticoagulation in patients with atrial fibrillation. A great deal of thought and effort went into making the BPA alert useful without contributing to alarm fatigue. When the BPA first launched, some patients were incorrectly notified that they had atrial fibrillation and were not anticoagulated. Concerned patients contacted their providers, who ultimately contacted the PPSS investigators at the University of Florida, Gainesville. The source of the error was traced to the electronic health record, which was unable to distinguish between diagnoses considered as part of an initial workup, but later ruled out, versus patients with an active diagnosis of atrial fibrillation. This problem was noted in other studies that rely upon electronic health record administrative data, and the University of Florida Gainesville is working with the electronic health record vendor to permit automatic updating or reconciliation of medical records. The second arm of the triad, clinician education, was implemented in two parts. Fred Kusamoto, a nationally recognized heart rhythm expert and co-author of numerous clinical guidelines, gave a grand rounds presentation that discussed challenging yet common situations in anticoagulation therapy for atrial fibrillation. The Grand Rounds event was offered for 1 credit hour and is available online to subscribers of the Heart Rhythm Society's educational website for healthcare professionals, heartrhythm365.org. The other component of clinician education was an online self-assessment module. Primary care providers were surveyed for their educational needs concerning anticoagulation guidelines in atrial fibrillation. Educational objectives were developed based on clinical situations the primary care providers found most challenging to address. A total of 17 questions were developed to meet these educational objectives. The self-assessment module was offered for 2 credit hours and is available to subscribers of Heart Rhythm 365. In the screenshot shown here, the learner is asked to select the guideline-recommended combination and sequence of anticoagulant and antiplatelet therapy for a patient who has a recent history of percutaneous coronary interventions with abnormal stress test results. Once the learner responds, the answers are provided with teaching points and a performance summary from other learners. This feedback permits comparison with a peer group, which is a tenet of best practices in adult education. The correct response is highlighted in green, and the incorrect responses are highlighted in red. After participating in these clinician education activities, the learners recognized previously unknown gaps in their knowledge and skills using anticoagulation therapy for atrial fibrillation. The activities have been well received by primary care clinicians. The third arm of the triad was patient education. Patient communications were provided depending upon individual risk of stroke and anticoagulation status. Patients were sorted into one of 3 groups. Only the first 2 groups of patients had CHADS-VASc scores that met the criteria for anticoagulation therapy use. Group 1 comprised patients at high risk who were already using anticoagulants. These patients received communications intended to encourage their continued adherence to therapy, noting that anticoagulation therapy reduces the risk of stroke. Group 2 comprised at-risk patients who were not using anticoagulants. These patients received communications informing them of their increased risk and urging them to follow up with their provider as soon as possible to discuss risk reduction strategies, including anticoagulation. Group 3 comprised patients who are not currently at increased risk for stroke and who are not candidates for anticoagulation therapy. These patients were encouraged to follow up with their provider if they had questions about their stroke risk. All 3 groups were encouraged to visit the Heart Rhythm Society patient education website, upbeat.org, for educational information on reducing their risk of stroke and the benefits of anticoagulation therapy for patients who need it. All 3 groups were also surveyed for their opinions about the usefulness of the provided information. The wording of these questions varied depending on the group. Most of the patients who completed the survey indicated that they were planning to discuss their stroke risk with their provider, with the highest intention to discuss in Group 1, the patients who need anticoagulation and are already on anticoagulation therapy. Overwhelmingly, patients in all groups agreed that the upbeat educational materials were understandable and useful. Of concern within Group 2, the patients who needed anticoagulation but are not currently on therapy, 25% reported that they had been told by a clinician that they no longer needed anticoagulation therapy. This suggests an educational gap to be addressed in future QI initiatives. The PPSS was designed as a pre-post intervention at a total of 14 outpatient clinics associated with the University of Florida Gainesville. Cross-sectional results were collected for 6 months from October 2021 to March 2022, and again from October 2022 to March 2023. A total of 3,274 patients were analyzed post-intervention. Did the PPSS meet its goal of increasing guideline concordant anticoagulation in patients with atrial fibrillation? Let's look at some of the results. At baseline, even the lowest performing University of Florida Gainesville clinical site participating in the PPSS had anticoagulation rates that exceeded the National Cardiovascular Data Registry Pinnacle median. However, the difference between the highest and lowest performing sites was about 20%, a concerningly wide variation between clinical practice sites. The aggregate anticoagulation rate for all clinics increased from about 75% to 78%, although this change was not statistically significant. However, when the results were stratified by practice site, statistically significant improvements were seen in 7 of the 14 clinics. These spaghetti plots show the changes in anticoagulation rates for each of the practice sites. Sites with statistically significant changes are highlighted. There is less variation in anticoagulation rates among the clinics post-intervention than there was at baseline. Another important finding was that patient engagement mattered. Patients with an activated MyChart status were much more likely to receive anticoagulation than patients whose MyChart status was inactivated. Each intervention in the triad model was introduced sequentially. The BPA was introduced first, then the clinician education, and then the patient education. Here is an example of the year-over-year comparison before and after the intervention for a single clinic. It is encouraging to see that improvements were observed even though the anticoagulation rate at baseline was 78%, because the higher the baseline, the more difficult it is to show improvements. Current ACC, AHA, ACCP, and HRS guidelines for the management of atrial fibrillation prioritize DOACs over warfarin for anticoagulation therapy for patients without moderate severe rheumatic mitral stenosis or mechanical heart valves. The North American Thrombosis Forum, or the NATF, offers a number of resources for clinicians and patients about anticoagulation therapy. Download the practice aids for a convenient chart outlining the currently available anticoagulants and links to NATF educational resources. Among patients using DOACs, apixaban was selected for approximately 4 out of 5 patients, followed by rivaroxaban for about 1 out of every 8 patients. Dabigatran was used by about 1 in 50 patients, and edoxaban was rarely prescribed. DOACs are generally associated with lower bleeding risks than warfarin, but patients often pay more out-of-pocket for DOACs than warfarin. However, warfarin requires international normalized ratio monitoring, while DOACs do not. Reassuringly, DOACs accounted for a gradually increasing proportion of anticoagulants prescribed within all demographic groups. This finding suggests the Quality Improvement Initiative increased DOAC use without worsening health disparities by sex or race or ethnicity. In people with normal kidney function, the rates of anticoagulation use stayed about the same before and after the intervention. However, there was significant improvement in anticoagulant use in patients with chronic kidney disease after the intervention. One plausible explanation for this is the limited data available to guide the treatment of patients with chronic kidney disease due to their underrepresentation in clinical trials. Moreover, patients with chronic kidney disease are always considered to have a higher risk of bleeding. These factors may have contributed to clinician reluctance to prescribe anticoagulation therapy to this group of patients. After the intervention, clinicians appeared more comfortable prescribing anticoagulants based on the guideline recommendations. In summary, the PPSS addressed barriers to appropriate anticoagulation use at 3 levels: the practice, the provider, and the patient. The initiative increased appropriate anticoagulation therapy for stroke prevention for many patients with atrial fibrillation at half of the participating clinics. The ultimate implementation of the PPSS was well received by clinicians and patients. Implementing the Quality Improvement Initiative required the skills and collaboration of many people and organizations, including clinicians, administrators, as well as specialists in certified continuing medical education, professional development, and quality improvement. We especially thank the University of Florida, PeerView Institute for Medical Education, and the Heart Rhythm Society, who worked to make this QI initiative a success. That concludes our presentation for today.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MXE860. This activity is supported by an educational grant from the Bristol-Myers Squibb and Pfizer Alliance.